Some of the results that I've seen are so dramatic. It seems as though they've had a rhinoplasty.
By filling a valley next to a hill, we can make the hill become less prominent. But it does not address.
How does filler in the nose differ from other areas of the face?
There is a very, very rare risk of partial or complete blindness. One of the really cool things that I do to minimize that risk is.
Oh, that is amazing. I didn't know that it actually could feel like bone.
Radix is essentially a hydroxyapatite or liquid bone. Non-surgical rhinoplasty is really appropriate for a select few patients who come in. And it really is only appropriate for.
BeautySeek is not a medical provider. This is not medical advice. Always consult a licensed professional.
Dr. Sayah, welcome. Some patients aren't ready for rhinoplasty, financially or emotionally, and yet might want to see what their nose would look like with a non-surgical procedure. For those who hear that non-surgical rhinoplasty is an alternative to surgery, how would you explain what it is?
It's actually a great question. We are asked that question several times, I would say a month. So non-surgical rhinoplasty is really appropriate for a select few patients who come in. And it usually involves injecting filler into the radix, which is where the nose meets the forehead, right about here. It's right lower than where your frown is. And so for patients who happen to have a bump and have a radix which isn't very high, we can fill this part of the nose with some filler, and essentially by filling a valley next to a hill, we can make the hill become less prominent. And it balances out the nose, makes a nose longer, more aesthetic. It can also correct asymmetry in the nose. If someone has a kind of a more very protuberance on one side, we can add a small little bump on the other side and bring it into balance like that, so the nose will not appear crooked. But it's usually for a softer or more gentle change to the nose, which can actually have quite a dramatic effect. But it does not address all the different anatomical structures of the nose that we can refine in a surgical rhinoplasty. So again, it really is only appropriate for very few patients.
Okay, some of the results that I've seen are so dramatic. It seems as though they've had a rhinoplasty. Is there a particular type of filler? I know there's all kinds. What do you lean toward or suggest?
For those who are starting out, I would suggest the fillers that we could dissolve in case they happen to not like it. And so the hyaluronic family of fillers, and those include Juvederm and Restylane, are composed of hyaluronic acid. They tend to last anywhere from 18 months to 2 years. And they don't go to about 2 years and then all of a sudden overnight disappear. Every month they tend to go down. And if the patients have it done and go, my gosh, I happen to not like it, or can we decrease it a little bit in this area, it can easily be dissolved. And then even within that class of fillers, there are different grades or thicknesses to the hyaluronic acid. The hyaluronic acid has cross linkages, kind of like Jello, and it forms a 3D mesh. And so just like in Jello, when you can add more gelatin, the Jello becomes thicker. Hyaluronic acid comes in either super thick gel, medium gel, or thin gel. And for the nose, because it's more structural, the nose is more firm. I tend to use the more firm hyaluronic acids because they tend to hold their structure and stay in one place more. Whereas if I was doing the under eye tear troughs or the lips, I'd use the thinnest of the hyaluronic acids. So once the patients have had the filler of hyaluronic acid and they go, oh my gosh, I've had this done once or twice, I happen to love it, then we can go to something more permanent like Radix. Radix is essentially a hydroxyapatite or liquid bone. And I inject it slightly differently. I inject that directly onto the bone. And actually, as I'm injecting it, I actually scrape the bone a little bit with a needle. Of course, the patients are numbed ahead of time, so they don't feel this. It's all done in the office. There's no downtime except for some swelling. And so the radius kind of adheres to the bone and tends to last longer than the 2 years and really feels like bone. So that would be the second class of fillers which I could use in the nose to accomplish a non-surgical rhinoplasty.
Oh, that is amazing. I didn't know that it actually could feel like bone.
Absolutely.
Perfect. Okay, you talked about what a liquid rhinoplasty can address, a dorsal hump or non-symmetry. What can a liquid nose job not do? What kind of nose is not the best?
Great. So I'm sure you can envision people who come in and they just have an extraordinarily large nose. The nose is tall, it might be wider, it might have a very prominent hump. Some patients come in with a large nostril. Some patients come in with a drooping tip. Those are all the different characteristics of a nose that a surgical rhinoplasty would be more appropriate for, because in a typical surgical rhinoplasty, I can actually lower the nose so it's not so tall, narrow it, raise the tip up, refine the tip even so it's not so bulbous. Sometimes we can add cartilage grafts. So those are all the refinements that won't be possible with a liquid rhinoplasty or non-surgical rhinoplasty. And of course, in a secondary rhinoplasty, if someone comes in and they've had a not so perfect result from a prior rhinoplasty, those patients usually would benefit from a surgical rhinoplasty versus a non-surgical, though in patients who've had over-resection, as in particularly in the older type of rhinoplasty where it was in fashion to just take so much out of the nose as surgeons try to refine it, in those patients we can add filler to the nostril or to imperfections in the nose, and that's really an easy fix. In fact, I happen to have a celebrity singer from Germany who came to me, and she had at a very young age, an overly done nose. Well, the nose was way too small for her face, had all types of different imperfections and asymmetries, and we did filler on her. And after doing the filler a couple of times, she said, "I love this, but how do I make this more permanent so it doesn't go through the hills and valleys? It always looks great." And then she opted for a surgical rhinoplasty where I used cartilage from cadavers, and then I reconstructed her nose using the cartilage. So that's another kind of category of patient who, after having done the liquid rhinoplasty or the non-surgical rhinoplasty, may then opt to have the surgery once they know what it feels like, because they don't want to have the hills and valleys, because the filler just keeps going down, goes up, and they want to just keep the best look full time.
Yeah, and how beautiful that you can do a test run before you actually commit to the surgery. I think that's
Yeah,
great.
absolutely.
Does the thickness of the skin, some of us have thinner skin, some thicker, does that affect how results will look?
I think that's more secondary to the structure of the nose to begin with. If patients are a candidate for the non-surgical rhinoplasty or the liquid rhinoplasty, then I think the next variable that you brought up is important to note. Patients with thicker type of skin need kind of more filler, more structure to bring the skin out. I think in the liquid rhinoplasty, thick skin is not as important as in a surgical rhinoplasty. In a surgical rhinoplasty, I often describe the thick skin using an analogy of a blanket. If you have a thick blanket over a very delicate structure, you have no idea what the structure is under the thick blanket. All you know is, okay, there's a bump there, but you can't really figure out the structure of that object. Whereas if you have a really thin silk on top of a structure like a Rubik's Cube, you'll be able to make out, oh God, this is really a Rubik's Cube. It looks like it, it's got the shape, the dimensions. You might even be able to see the little the little depressions in between the pieces of the Rubik's Cube if it's a very thin silk. But again, in a thick blanket, that wouldn't be possible to appreciate. So in a surgical rhinoplasty, when we're trying to bring out the fine, delicate details of the nose, everything from the supratip depression, delicate nostrils, those fine refinements are less possible with thicker skin, because the thick skin will, again, just cover up all the fine detail underneath in the structures. Whereas in a thin skin person or even average skin person, those delicate structural changes will be much more noticeable. So what do we do then? In a regular rhinoplasty, I go in there and actually thin the skin from the inside, and that way we can bring out the structures better, or sometimes slightly exaggerate the appearance that we want to create such that it's even more visible through the slightly thicker skin. So between thinning the skin and accentuating the changes that we want to see, we can create almost similar results as someone with thin skin, but never quite that detailed.
Fascinating, fascinating. How does filler in the nose differ from other areas of the face that we are getting filler, like lips or cheeks? Is it injected differently, or what considerations do you take that would be different for the nose?
Right. As I mentioned, the filler material is pretty much the same. I would still start off with a hyaluronic family of fillers because they are definitely safer, and if patients don't like them, we could dissolve them. Then we talked about the different classification of fillers, even within the hyaluronic family, where if I'm doing under eyes or lips, I'll choose a thinner gel versus something more structural like the nose or the cheekbone, where I use the thicker category of hyaluronic gel. And one last consideration is the risk of having an embolus. And so near the center of the eyes or the glabella is close to the eyes, and there is a very, very rare risk of an embolus where the filler material can actually enter a blood vessel and go to the eye and cause partial or complete blindness. So again, it's extremely rare. I do mention it to the patients, but that would put filler into the nose or the liquid rhinoplasty in a more risky kind of category than fillers into the lips or the rest of the face. Emboli or clogging an artery can happen in other parts of the face too when we inject them, but those areas are not as critical as our vision. And so it's really important for me to bring that up with the patients and mention to them that this is a risk, although exceedingly rare. As with other types of elective surgery or cosmetic surgery, it's really important to always compare the risks with the benefits. And so we really need to make sure the benefits are way up there, the risks are way down here to make the procedure worthwhile. As the risk goes up and the benefit goes down, then we get to a point where we have to decide, is this really worth it? So if a patient is an excellent candidate for liquid rhinoplasty or non-surgical rhinoplasty, then I think the benefits typically do outweigh the risks. And then with the technique, there are also gentle, subtle technical differences in the way that the procedure should be done. For instance, one of the really cool things that I do to minimize that risk is I inject on the way out. So I firstly numb the patient, I put the needle in, and then as I'm withdrawing the needle, I inject the hyaluronic acid gel such that it minimizes the risk of the needle going into a blood vessel. There are also blunt tip needles that theoretically don't pierce blood vessels to as much of a degree as sharp tip needles. And those blunt tip needles would also theoretically decrease the risk of having an embolus.
I love hearing this. We always want to know about the risks. I was reading some journals, and I think vascular occlusion can result in about 0.0225% of all treatments. But I was talking to my injectionist, and she said, you do enough of them, and the chances are that it could happen. So what would you look for? How would you monitor the skin to see if something like that is happening during a procedure?
Right. The visual changes are pretty instant. And so patients typically say that I I think there's a little bit of a change in my vision. I've been in practice for 25 years, and I can confidently tell you that we've never had this happen to me. And so I'm usually very delicate when I do the fillers. I think most important thing is avoidance. Avoiding an issue is the most important. But there are things that we can do once it does happen. So if a patient experiences this in the office, which is generally when it would happen, we go in there and we dissolve the filler, and then they're of course sent to the emergency room, whether they want hyperbaric oxygen, more enzyme to dissolve the filler in a few hours. So there is kind of a protocol that we follow to help us recover, though in many instances the vision and the visual changes does not come back. So it's extremely rare that it should happen. When it does happen, it's very serious. We watch the patients always for a few minutes after they've had the fillers to ensure this doesn't happen to them. But let's really emphasize prevention before we get into treatment.
Okay, I'm so glad you shared your technique, the blunt tip, the pulling out as you're injecting. I hadn't heard any of that. And we might go a little bit off a topic here because I was speaking to my injectionist, just about the skills and the training required. And she shared with me that in Minnesota, where I am, and Texas, to do injections, you don't even need to be a registered nurse. You don't need to necessarily have education on the anatomy. And that just blows me away.
Things have changed a lot. So I'm in Beverly Hills, California, and I think California is probably more liberal when it comes to who gets to inject and who doesn't. So in California, firstly, dentists are permitted to do plastic surgery. And I'll let your viewers decide how they feel about that. And the whole injectables business, of course, started with doctors and surgeons and dermatologists and plastic surgeons. And then as time went on, other doctors kind of said, wow, this is a fantastic, profit center for my practice. Why don't I offer it to my patients? And those doctors might be any specialty you can imagine, from OBGYN to emergency to anything. More and more doctors started to open up these cosmetic centers, and then the med spa business started to flourish. And now I can confidently tell you, speaking with the pharmaceutical reps that sell us our fillers and Botox, they definitely confirm that most of the people that are performing fillers these days are nurses. So nurses can open up their own little med spa, and they're usually less expensive than a trained plastic and reconstructive surgeon such as myself. And patients gravitate towards those centers because they're easier to get in and get out. They might be in a little mini mall. They don't have the same criteria or, of course, I would say safety assurances of a proper medical office. But then going back to what you said, yes, more and more nurses or PAs are performing injectables here in California, and the med spa business is booming. But as you can imagine, it's not necessarily legal or proper. Those practices do have to have a physician overseeing them. And, many times the physician is hardly there. They just sign off. And the nurses or the PAs are running the practices on their own. It doesn't mean that's always the case. I'm sure there are medical spas that are physician owned and operated, and the physician is on site. So it's really important for your viewers who are going to have injections done by a nurse to please make sure there's a physician on site, there's a physician overseeing the procedure. And as with anything that we do in life, it's really easy to get it right. If you do it 100 times, people become really confident and they become really good. And so it's not necessarily the technique that's important, it's rather how do you avoid problems? Because God forbid when a problem happens, that's where experience comes in. And same thing in surgery. Just like with injectables, where we have so many nurses and PAs that are doing the procedures in plastic surgery, there's so many non-qualified doctors that are performing plastic surgery. And based on California law, you don't have to have a formal training in plastic and reconstructive surgery to perform plastic surgery. So any doctor after medical school, after a year of internship, can perform plastic surgery, and it's absolutely legit. So again, it's to do liposuction, really easy. To do breast augmentation, super easy. And doctors get quite good at it after doing a few hundred. But again, when something goes wrong, that's where experience comes in. And things do go wrong. And surgery is very detailed. It's all about experience. And so again, please, if you are contemplating having plastic and reconstructive surgery, please make sure your surgeon is board certified by the American Board of Plastic Surgery. Check into their credentials. There's several boards that are kind of made up boards, the Board of Cosmetic Surgery, Board of Liposuction Surgery, etc. So please make sure it's the American Board of Plastic Surgery, just to be sure that your doctor is properly trained. And if you have the option, always go with the safer one. It's your health. Yeah, it's your health. It's the most important thing you have. Don't jip yourself.
Yeah, no, we need to advocate for ourselves, and those are all of the right questions. Question then, if something does go wrong, what does an injectionist need to have on site? Is there materials, medication, a bag of ice? What should they already have there to try to rectify the situation?
Right. At the most simple level, ice is really important. After your procedure, it's really important that you begin icing right away. It minimizes swelling and bruising. And even before your injection, it's important to stop all anti-inflammatories such as Advil or Motrin. If you're on blood thinners, talk to your doctor to get their permission and blessing for you to stop your blood thinners, because otherwise you'll swell up and bruise more from your injections. Make sure that your healthcare provider is aware of all of your health conditions to make sure there's no contraindication to having the injections done. With that said, after the procedure, again, begin with ice. And if there is an unwanted complication after your procedure, the most important thing to have in the refrigerator is called hyaluronidase. Any protein that has an ACE at the end is a protein that breaks down the chemical name of what's in front of it. So if we want to break down hyaluronic acid, we use hyaluronidase. And so we have several vials in our refrigerator. It's important that your healthcare provider has a few of those, because if there is an embolus, God forbid, it's really important to dissolve the filler right away with a much higher dose of this enzyme than we would ordinarily use.
Okay, so do you think it's appropriate for a patient, a client, to ask before a procedure, hey, just checking, I just want to make sure in case something goes wrong, do you have hyaluronidase on hand?
I think it's important. And you know what happens? I think patients are sometimes shy, maybe timid, or maybe their friend had a fantastic result, or their loved one, and they go, oh, this doctor is so fantastic, I don't need to bother. But I think it's a good question to ask and say, listen, I heard Dr. Sayah, he said that it's so important for you to have some of this on hand. Do you have some hyaluronidase just in case something goes wrong? I think it's an appropriate question. As long as it's asked politely, I think the healthcare provider would be more than happy to give them an appropriate answer, and they should have some on hand. It's a little bit expensive to keep it on hand, but again, anybody who's doing injections these days, a filler material should have some in their refrigerator.
Okay, perfect. Safety question. What about the speed of the actual injection? Does that matter? I was getting PRP under my eyes, and a trainee was working on me, and then the trainer saw that she was moving slowly, said, let's move this along. So is speed important with injecting the nose, or is that different PRP?
Speed is relative, as you can imagine, right? So if you had someone training on you, I'll leave that with you. I wouldn't want anyone training on me. But then again, that's the spirit of medicine and healthcare, just so you know. We do have an obligation to teach, which is what you and I are doing right now. We're teaching not just the public, but hopefully a few healthcare providers will come across this as well and take a few pearls of wisdom from it. So there is an obligation to teach such that others who follow can practice the art of medicine. And so then we'll move on to the speed. I think as long as it's done carefully and you know that your healthcare provider is being meticulous and careful, I think that's good enough. It's really, it's probably impractical for you and I to say, oh, it should take, 5 minutes to do this and not 4 minutes. And so we just have to know that whoever is doing the procedure needs the time that they feel comfortable with and prepping and everything. And so as long as it's not extraordinarily long, I think, I would defer to the healthcare provider to go at the rate that they feel is comfortable. Because certainly if they're going too fast, one might say, well, they're not being as careful as they should be. So you'll know. It's a feel, much more than how I can describe it. I think it's a sense of comfort and rapport which patients should have with their doctor.
Yeah. And you do bring up a good point, because to this day, I still didn't feel comfortable that I had a trainee working on me. She just walked in and asked and put her hand on my shoulder, and I said, okay. But yes, she needed to be trained. So,
well, I should add in academic centers. So I trained at UCLA, and for me to be here speaking with you, 25 years after I completed my fellowship at UCLA in plastic and reconstructive surgery. So for me to get the training that I needed, I had to operate on patients. And so it is, again, an inherent part of our healthcare system that residents and fellows, even medical students, do need to learn. But then the patients do need to consent. Informed consent is super important. Patients need to be aware. And even in surgery, as we're training, there's, of course, always a professor that's watching every single step. And we're not put in a position as residents or fellows where we are in over our head. We start with very small procedures, even from putting an IV in, and then we kind of move up to much bigger procedures as our skills develop and as our experience develops as well. So again, my compliments to you for allowing that person to learn. And you actually helped to train someone who will benefit society moving forward, because probably besides fillers, there's other skills that they learned, which they will in turn pass on to others. And then in surgery, again, typically it's part of the informed consent process. But if any patient ever doesn't feel comfortable having a trainee, resident, or fellow be in on the surgery or assist with the surgery or partake in the surgery, they can always tell the primary surgeon, and I'm sure the surgeon will respect their wishes.
Great. Perfect. Well, you've been practicing plastic surgery, if I've done my research correctly, and you probably stated it right now, and reconstructive surgery for nearly 25 years. And I'm sure you've seen a lot of beauty, and a few procedures may have arrived at your door for revisions. Anything you can tell us in terms of like the most beautiful noses and some that, gosh, we needed to work on the nose in this way?
It's really a great question. So I've been in practice for 25 years, and I should highlight that in the past 25 years, I've never had any nurses or PAs perform any injectables in my office but myself. So although I'm a surgeon, I do all my own injectables myself. I take great pride in doing everything myself, whether it's injectables, the surgeries, or even removing stitches. And then to answer your question about kind of what's going on in plastic surgery, it's so interesting to see trends in plastic surgery come and go. So when I was in my fellowship doing facelifts, the vector or direction of a facelift was entirely different. It was more kind of back and up. And I always kind of thought, and I would say, how come you're not pulling the face only upwards, because we're aging downwards with gravity? So when I first went into practice, I would do a vertical facelift, and now, 20 plus years later, that's becoming a trend. Next thing was when fillers came out, the pharmaceutical reps would teach us to inject it in little pearls, and then you would massage the pearl such that it becomes a shape. And I always injected the fillers in a three-dimensional shape with a needle under the skin, which is really cool because you can change the pressure on the plunger on the syringe and deliver different amounts in different locations as you're withdrawing the needle. So I always injected more three-dimensionally. And again, the reps would cringe and go, Dr. Sayah, that's not the way you're supposed to do it. I go, don't worry, it's going to be great. And now, again, 20 plus years later, when they teach fillers, they're teaching it to be injected in 3D shapes, as I described. So medicine has always evolved and will continue to do so. For instance, the whole Brazilian butt lift trend that came and is going away. If anything is so exaggerated, I would ask your viewers to really think about whether it's something that's long-lasting, or is it a fad that's going to go out of fashion in a couple of years and then they'll come in to reverse it. And so it's a very personal decision. I think to have a natural, balanced look is much more long-lasting than something which is exaggerated too much. And so, again, I would ask patients to envision themselves in 20, 30, 40, even 50 years and say, okay, how will this look on me? How will my, triple D breasts age as I become 60? Mm-hmm. Or how will my Brazilian butt lift look as I become older? Because guess what? Both the large breast and the large buttock age. And aging happens with gravity, and gravity is going to pull them down. And so if you can imagine all those patients who've had the Brazilian butt lift, all those butts are going to start sagging big time. Mm-hmm. And so in my practice, we have always emphasized a natural balanced look. So whether patients want a breast augmentation, we can make it significantly larger, but something which is more appropriate for their figure, maybe accentuated slightly greater, but not to the degree that it looks unnatural and doesn't age well with them. Mm-hmm. But that said, we're really into the patient's wishes and respect them. It's all about their happiness. And so I have done large breasts, beyond what would be proportional. And I really strive to make sure the patients are first healthy, happy, and satisfied with the outcome, not just short term, but long term. And so I would really ask and implore that your viewers and patients take a considerable amount of time to decide what they really want. Is it really appropriate for them? Is it a good, safe, long-term option for them? And take small steps, not big jumps.
And you performed many rhinoplasties and developed a truly unique techniques in terms of cartilage and so forth. Clearly, you understand the anatomy of the nose. How does prior rhinoplasty surgery affect if you were to use filler afterwards to do some touch-ups?
I think it's perfectly fine if somebody has a less than perfect result, or maybe a result that might look good, but they happen to want something else. In those cases, fillers can be an option. It's not always an option because sometimes we need to make things smaller, not bigger, to kind of get to the patient's goal. But if there is a slight imperfection, or if we can't fill in a small little area to give the patients the appearance they wish for, it's super easy to do fillers. But again, prevention is key. So in my practice, I ask the patients to bring me images of noses that they wish for. And among those images, we pick out their very favorite, and that will become our goal and reference point in rhinoplasty. So I stick that image on the wall in the operating room, and that will be kind of our goal as I change the structures inside. So with that technique, I'm able to really get really close to their wish images. It's never quite there, as you know, because there's so many variables that go into the nose and the balance of the appearance of the nose with the face. But it's best to get it right the first time around. And if not, yes, liquids and fillers can improve an imperfect result if the patients wish, but not always.
Dr. Sayah, in one of your interviews, you've said that what you do is the perfect combination of art and medicine. Can you talk about that a little bit?
Of course. Plastic surgery is the most artistic field in medicine. I'm sure you can imagine that. And whether we're doing fillers are really sculpting. And so after I inject my filler, I then work it like clay and I actually sculpt it with my fingers to be sure it has the shape that I really want it to have. And so I've always said that I feel sorry for plastic surgeons that don't have artistic skill, because it may not necessarily be something they can learn. So plastic surgery is absolutely art. We can only work with the material that we're given, and that's the patient's body, of course. We typically only get one go at it. You can't just come back tomorrow and keep working on it. And so we need to work with the material at hand over a limited period of time, and we need to create really amazing results. So it's absolutely art. And I love the field. I have to tell you, I'm so passionate about it. There's no other field in medicine like it. Other surgical fields also have a level of art to them, but typically they're so, I'm a general surgeon, and then I became a plastic and reconstructive surgeon afterwards. This is kind of what we call the more classic or hardcore way of being a plastic surgeon. And then while I was in my general surgery training, for instance, when we're doing a colectomy for cancer or whatever you might say, ophthalmic surgery. Yes, we do operate. Yes, you do have to have fantastic finesse with your hands, and you have to understand the anatomy, but you're not really improving the shape of what patients are born with. Whereas in plastic surgery, we have the responsibility to take what patients are born with and improve upon it to get it to be something even nicer, while keeping it healthy and safe. And that's a tremendous responsibility, because I always tell people that I take patients who are absolutely healthy, and I take them and I make them slightly sick just to make them more beautiful. And that's a tremendous responsibility. And we have to really understand risks. We have to be ethical about how we go about doing this. We have to have the right purpose. And but with all that in mind, I really am quite passionate about the artistic field of plastic surgery, which I have committed my entire life to up until this point.
It's clear you're very committed, and I appreciate just the love of what you do. I can feel it. How can you tell us a little bit about your background, where you've come from, how you've gotten to where you are to become the expert that you are?
Of course, a little bit personal. So I'm originally from Iran, immigrated to first San Francisco and then Los Angeles in 1980. And I was a public school kid, attended UCLA for undergrad and medical school, majored in biochemistry in undergrad. Never took any shortcuts. I was kind of, the hardcore guy, really loved medicine. My father was a doctor, and I, ever since I was born, wanted to be like him. He was the first most influential man in my life, and interestingly, the second most influential man in my life was my prior chairman in plastic and reconstructive surgery at UCLA. So growing up, I did lots of art. So again, growing up, everyone said you should be a plastic surgeon, and I said, no, patients are beautiful the way they are. I don't want to mess with them. I don't want to ever promote plastic surgery. And I want, because my father, at a very young age, had complications with his vision, I was really passionate about being an ophthalmologist. So I went to UCLA med school thinking I'd be an ophthalmologist, and then changed my mind shortly after because I realized, God, it's such a small area. I really want to operate on everything. I don't want to just always be operating through a microscope. I went through a couple of different specialties until I went to a lunchtime lecture by my then chairman at UCLA called Dr. William Shaw. And he was a really soft-spoken guy from China, extremely a gentleman. He was really just a fantastic guy. And during this lunchtime meeting at UCLA, I saw his before and afters. I loved his demeanor. Went and spoke with him right afterwards, and I said, God, I'm considering being plastic surgeon. He said, okay, David, go to NYU, finish your general surgery, and then come back to UCLA. And that's what I did. So I went to NYU, studied general surgery, a lot of intense trauma, a lot of gunshot wounds. It was people who know general surgery know how intense NYU is. Fantastic training. I'm forever grateful to my then professors in general surgery who really taught me my surgical skills. Then I came to UCLA, which was definitely the top program in plastic surgery at that time, and still is one of the top. And had a really fantastic training by some of the world leaders in plastic surgery in various aspects of plastic surgery, because even plastic surgery has different categories, whether craniofacial surgery, microsurgery. And after UCLA, I decided to go into private practice, and I've been in the same office now for 25 years.
Fantastic. Well, thank you for going through all of that education. So your patients and maybe me someday can experience your talents.
Of course. I'll be happy to meet them.
Yes. You remind me of some of the research that I've done and where plastic surgery even began was, after soldiers were, deformed basically after war. And I think that's a very noble beginning. And I'm fine with women, men wanting to look their best, wanting to change or alter their look so that, they can just kind of move over and move beyond that. And then on the other hand, some of us, we're just emotionally vested in, constant improvement. Is there ever a point in time when someone's talking to you about rhinoplasty or liquid rhinoplasty, 5-minute nose job, where you would say, no, you're just not ready for this?
I would say probably a couple of times a year. And not because they're not ready. I think that's less frequent than that, but rather it may not be the right procedure for them for various options. And I may not be the right surgeon for them, particularly because of my personal taste of keeping things balanced and proportionate and not overdoing things. And so I would say probably once or twice a year, we get a patient that I think, we may not be the right surgeon for, or the procedures that they're asking are too risky for them for whatever reason. And so sometimes there are health limitations. For instance, if somebody is on blood thinners and has cardiac issues, the risk-benefit ratio is just not worth it. So, and that is not a personal decision just by me. We have to always weigh the risks. And so it does happen where surgery may not be the right option for patients. And so the most important thing is to have a really wonderful dialogue during the consultation. Make sure the patients have practical expectations, they're healthy, and it all starts from rapport. It all starts from making sure that we understand each other, and such that I can make sure they get the results that they expect in whatever manner. Our consultations are about 45 minutes long, and during that time, I spend a lot of time meeting my patients to understand them. Where are they in their life? Why now? That's probably the first question I ask my patients. Why now? Why not 5 years ago? Why don't we wait another 5 years and do it then? What has prompted you to come in for this issue now? And that really opens the book. And the decisions are typically very personal, but by understanding why now, why, I really kind of understand what their intentions are. Is it for the right reason? And thank God it always is. But that rapport is extremely important.
I couldn't agree more. And I love that why now. As you were asking that question, I thought, gosh, here's the ways that I would answer that. I went through a consultation once, and the first question I got was, so what is it that you don't like about your appearance? And that kind of hurt.
Yeah.
So perfect. This has been so great. Can you tell our community a little bit about your practice, your location, how someone can get a consultation with you? What are the steps someone should take?
Well, first, I have to thank you and your viewers for attending this. I know everyone's time is so precious, and so I don't take it for granted. So as I mentioned before, I've been in practice for 25 years in the same office in Beverly Hills, California. We do attract patients from all around the world. And I say we because my practice isn't just me. It's me and my office staff. And this is our practice that we share together. So when you come, you'll see that we, as a team, take fantastic care of you. One of the things that I didn't get to highlight is that after I completed my fellowship at UCLA in plastic and reconstructive surgery, I spent a year practicing and studying endoscopic plastic surgery. So that is my forte. I do plastic surgery through minimal scars, whether it's a minimal facelift scar in the scalp, such that there are no scars on the face, endoscopic breast augmentation, where I go through the underarm, there's no scars on the breast, so you can be topless without any sign that you've had plastic surgery, or an endoscopic tummy tuck. There are other types of endoscopic procedures as well. And so I really emphasize small incisions. How do we minimize the number and the length of the incisions to get the job done? And I've refined a lot of techniques in plastic surgery, particularly in rhinoplasty, in fact, where I can, for instance, narrow the size of the nostrils without having the typical scar on the outside of the nose. I do it all from the inside of the nose, which is really cool. And so please, you're encouraged to contact us if you have any questions, regardless of where you live. With telemedicine, it has become so empowering to be able to meet people from around the world. And even if we don't get to operate, we still teach patients and empower them to make the best decisions for themselves, wherever they may be. And if we do have the pleasure of meeting you here in the office, I'd be delighted to share the surgical skills that I have perfected over the past many years. And I take a tremendous amount of responsibility in making sure that you get the results that you wish for safely and ethically.
Thank you. I will look at my air flights and see how quickly I can come out and visit. Thank you for the invite. I would love to come and visit. Thank you for your joy, your sharing your wisdom, your dedication to this lovely industry. I'm just enamored with it. And thank you for sharing your time today. I really appreciate it.
Thank you, everyone. Take care.
We acknowledge Dr. Sayah for contributing his professional insight to this interview. Expert perspectives like his support informed discussion around aesthetic procedures and beauty literacy.